predispose this patient to infection and, of course, infertility. In this case, we can see endometrioma, mass, which has higher density than the muscle, consistent with blood in it. And in this case, we can see endometrioma with a level of erythrocyte and plasma in it, so the diagnosis is more easy. But look at this case. It's very difficult to diagnose that we are talking about endometriosis. It looks exactly like peritonitis. What we see is infiltration of the fat at the omentum, at the mesentery, hyperemia of the mesentery. There is nothing specific that can lead us to the diagnosis of endometriosis. So we always should combine the clinical presentation with what we see in imaging. Endometrioma may be implanted in the location of former C-section scar, and it's very common to see these masses at the abdominal wall, and these masses may be painful every menstruation. Talking about infectious process, we are talking about PID. What happens in pelvic inflammatory disease is a bug that comes into the vagina, ascends into the uterus, causing endometritis. When it ascends into the fallopian tube, it causes salpingitis. When the infectious process is more severe, the fallopian tubes are filled with pus, and then piosalpinx occur. When this pus is spilled from the fallopian tube into the space between the ovary and the fallopian tube, tubo-ovarian abscess may occur. And this tubo-ovarian abscess may be associated with focal peritonitis or diffuse peritonitis. Actually, 34% of all women with PID will have tubo-ovarian abscess. The CT features of PID are diverse. They depend on the stage of infection. In early PID, the CT features may be very solid. What we see is mild fat effacement in the pelvis, thickening of the uterosacral ligaments, and peritoneal thickening. Here we can see a very sudden infiltration of the pelvic fat. Here we can see more severe fatty infiltration in the deep pelvic fat with thickening of the uterosacral ligaments. And here we can see thickening of the parietal peritoneum. If you don't look for these findings, you won't find it. When there is endometritis, abnormal endometrial enhancement may be shown due to the hyperemia of this inflammatory and inflamed endometrium. And when salpingitis occurs, then we start to see the tubes. Usually we don't see the tubes. Here we can see the fallopian tubes bilaterally very clear because the walls of these tubes is thickened and hyperemic, thus enhancing. When the ovaries are involved, we can see large ovaries with hypodense areas in it. So, as I mentioned before, when they ask for PID, look for these subtle findings. If you don't look for it, you won't see it. When the infection is more advanced, we can see dilated fallopian tubes, with thickened wall which show marked enhancement. And here we can see also inflammatory changes around these inflamed and dilated tubes. And when the infection is more severe, then we can see tubo-ovarian abscess. And tubo-ovarian abscess looks like an abscess anywhere else in the body, meaning a mass that contains an inoculation of fluid which is thicker than clear fluid, with thick capsules and thick septations. And it can be unilateral, it can be bilateral, but one thing for sure, you can't make the diagnosis of tubo-ovarian abscess without inflammatory changes in the pelvic fat, because multi-loculated mass can be not on infectious basis, and you have to see the changes in the pelvic fat to be sure that you are talking about infection in the pelvis. So, in conclusion, multiple entities, including normal physiological changes, may cause acute abdominal pain, and CT is the modality of choice for evaluation of acute abdominal pain. Many gynecologic conditions have characteristic CT findings, and knowledge of this finding is crucial to make accurate diagnosis. Thank you for your attention, and you are all invited.